Good afternoon, and I want to thank people for inviting us, Dr. McKinney, Dr. Fareed, and myself to the GYN-ONC webinar on the conundrum of anal cancer screening for the obstetrician and gynecologist. So a little bit about myself. I am on faculty at the Department of Obstetrics and Gynecology at the Beth Israel Deaconess Medical Center and Harvard Medical School, and I am one of the three of us who runs the anal dysplasia, lower genital tract anal dysplasia center here at Beth Israel Deaconess with Dr. Fareed and Dr. McKinney. Unfortunately, Dr. Fareed will not be with us today. Dr. McKinney is also on faculty in our department. She is the director of our vulvar center. And she's also, like I said, one of the three of us who specializes at the lower genital tract dysplasia center here. So just a little bit about disclosures. None of us have financial relationships or conflicts of interest with any financial relationships. And so before I go on, I do want to talk about a story. And I think this story will be a little bit telling and will help you sort of bring things together. This is a 51-year-old gravida-3, para-3, HIV negative, cisgender female who presents with fullness in her vagina. The past medical history includes a cold knife cone in college for cervical dysplasia, bilateral mastectomy with chemoradiation for ER/PR positive breast cancer, and risk-reducing laparoscopic BSO. She was known for regular compliance with her health care, and on pelvic exam, there was a large 7-centimeter anal rectal mass. Biopsy revealed anal squamous cell carcinoma. And the patient was referred to oncology and colorectal services. Imaging and biopsy demonstrated liver metastases, and she was diagnosed with stage 4 anal squamous cell carcinoma. She underwent multiple rounds of radiation and chemotherapy, and then she succumbed to her disease and died 2 years later. This patient was my brother's wife. And I tell you this not because it was severely, obviously, very difficult for our family, but because Susan, who was my brother's wife, had very limited risk factors for anal cancer. And I think in today's world, she would probably still, after 10 years after her death, still not have been screened for anal cancer. And I think, this is really the conundrum of this disease and why we're presenting this whole slide set to you is about, why the risk factors are just not there for us. And so, and I think I'm going to hand this off to Sara to talk a little bit about the objectives.
So some of the things that we wanted to go over today and kind of improve our general familiarity with is the epidemiology of anal cancer, what the numbers are, what specific populations are being affected, and particularly those relevant to us as OBGYN generalists. And then to understand what some of the roadblocks have been in screening from a primary care generalist perspective, understand how to screen for anal cancer, what are the risk factors, and to understand what the current guidelines are. And then finally, to get an introduction to what this new virtual dysplasia center is that we've established here at BI, so that you can have a better understanding of who to refer to the clinic. And so some of the things we're going to go over today, the first thing I wanted to kind of delve into involves the epidemiology and the numbers regarding anal dysplasia and anal cancer. So I think in learning about anal dysplasia and anal cancer, I was really surprised by the fact that women are disproportionately affected. So if you look at this pie chart, you can actually see that 2/3 of cases involve women, which, as an OBGYN and as a women's healthcare provider, that's not something that I really understood until, Dr. Ganz joined our faculty and really made us more aware of it. It's something that was a really big topic at the last ISSVD, the International Society for Vulvar Disease Conference, to kind of bring awareness to it. And so, one, our patients are being disproportionately affected. And the other thing that's really interesting about this particular condition is that the numbers have been increasing in the last 20 years. And so although the numbers for cervical dysplasia have significantly improved since we've improved screening guidelines, the same cannot be said about anal dysplasia. And it's hard to say why this is happening, and there are many theories and hypotheses regarding this, but we still don't truly understand. Is it as a result of higher number of solid organ transplants, higher positivity in certain populations? We really don't understand why we're getting this different pattern when compared to cervical dysplasia.
So I do want to talk about anal cancer screening. Actually, this is a great meta-analysis by Clifford and Steer and et al. In 2021. And if you look at this graph here, this is from 40 to 120, 100 per 100,000 person years. We clearly on this slide, we all agree that HIV positive MSMs who are greater than 60, 45 to 59, and 30 to 40 years old should all be screened. Everybody on this slide should be screened. Single organ transplant recipients greater than 10 years, people who've had vulvar cancer, and people who've had vulvar pre-cancer should also be screened. I do want to let you know that if you look at this, cervical cancer prior to pap smear screening in the early 20th century showed basically 40 to 50 per 100,000, essentially right where vulvar cancer is today. On this slide, we all agree that this is the lower part of the risk groups, and this kind of makes sense not to screen. If you look here, HIV negative MSMs, HIV negative females, Crohn's disease and its partner, ulcerative colitis, cervical precancer less than 40 years old, HIV positive non-MSMs less than 30, and HIV positive less than 30 years old, all are under around 6 per 100,000. And so if you, these are people that really don't need to be screened. And this is where the middle section, this is an area that is very difficult for us to screen because it's sort of right in the middle. If you look here, and just to give you a sort of a comparison, colon cancer represents about the risk for colon cancer in the United States is about 25 per 100,000. So we're looking at about here for colon cancer. But if you look here, we here at Beth Israel Deaconess Medical Center suggest to screen everybody on this list. And this is where it gets very tricky because a lot of the societies and colleges and the guidelines around this really don't, are up in the air on this. However, I think what's going to come around will show you why this whole area of HIV positive non-MSMs, HIV positive women greater than 45, and all the rest on this list should be screened.
So although the numbers have been increasing in the last 20 years, one of the positive things that have resulted in the last couple of decades is the improved media spotlight on this condition. So on the next page, you'll see a highlight regarding Farrah Fawcett. So, you know, prior to Farrah Fawcett, and it's still a little bit so still, but a lot of people had shame and there was so much stigma around presenting to their primary care provider regarding anal dysplasia, anal cancer symptoms, whether it was bleeding, anal discharge, anal discomfort. And Farrah Fawcett was one of the first celebrities to, especially female celebrities, to bring to light this condition. She was diagnosed in 2004 and battled this disease for 5 years. And during that time period, she actually documented her entire treatment process. And although she also succumbed to her disease, a lot of, wonderful things came of her legacy. She started a foundation where they raise money for research, assist patients in receiving treatment, and also helping change how a different center's protocol and approach screening and the guidelines for anal dysplasia. So, she helped really bring this disease to light for those populations that we don't tend to associate with anal dysplasia and anal cancer. The same can be said for the celebrity on the next page, Marcia Cross from Desperate Housewives. She also suffered from anal cancer. However, she is now in remission, and she really brought this disease to light in the last 10 years. And so, this condition has traditionally been really stigmatized, and unfortunately, and hopefully, with celebrities coming forward and sharing their journeys, patients will feel more comfortable, hopefully, bringing these symptoms up to whichever provider they initially present to.
So I do want to bring up this. It's one of the podcasts sponsored by the International Anal Neoplasia Society. It's called Going Viral, Don't Die from Embarrassment. I think this is one of the podcasts that's going to be available to really bring light about anal precancer and anal cancer. And the bottom line, it is a podcast for providers, patients, and really everyone in the realm of anal cancer. It's prevention, screening, and treatment. And it's going to have monthly interviews with experts in the field, patients, and family advocates. It's moderated by myself, who obviously is an anal dysplasia expert and gynecologist, and my dear colleague, Mary Jo Murphy, who is a nurse, an anal cancer survivor herself, and a patient advocate.
So one of the things we wanted to highlight are some of the roadblocks, both in patients presenting for care and providers being able to provide for care. So from a patient perspective, there's really, not much general teaching regarding anal dysplasia and anal cancer. We're all aware of, some of the guidelines regarding breast cancer screening, cervical cancer screening, colorectal or colon cancer screening, but not so much regarding anal dysplasia. And, sometimes a lot of patients will presume, I get my regular colonoscopy every 5 to 10 years, but forget that anal cancer is screened differently and can often be missed by procedures such as colonoscopies. The thing we've already touched on as well is the psychosocial and stigma associated with this condition. There can be a lot of shame and embarrassment regarding the symptoms that patients may present with, and patients may not know who to go to. Do I have to go to a specialist? Can I talk to my PCP about it? Would I bring it up to my gynecologist? And then being unaware of the risk factors that would put somebody particularly at risk for this condition, so that patients can actually advocate for themselves. And then from a provider's perspective, something I just touched on is who owns this condition. Is it the gynecologist? The anus is quite close to the vaginal opening in the perineum, which tends to be our domain. Is it the colorectal surgeon? Is it a primary care doctor? Is it a GI physician? There's a lot of overlap, and it isn't always clear who should be implementing these screening processes and identifying patients at risk. And same with, in terms of educating our youth, because of the, the ownership among different specialties. Unfortunately, a lot of the guidelines, the experience with this condition gets lost. And, I remember being a resident and my preceptors asking if I had done a digital rectal exam and being taken aback, like, why would I do that? That's not something I was trained to do as a gynecologist. But that can actually be an important aspect of the exam when screening for anal cancer. And then being, in terms of the guidelines, as you will see in a later slide, there are many different organizations who have fortunately provided guidance on how to screen and manage this condition, but that also puts a lot of cooks in the kitchen and makes it difficult to know whose guidelines should I be following. And then in terms of infrastructure, not all institutions are set up for, okay, this provider screens, and then I send this patient for the high resolution anoscopy, and then I send this patient to this provider for the management, whether it be, medication, ablation, or surgical excision. You have to kind of have all three in place, and that's not always possible at even, well-funded institutions. And so they've actually done studies where they've looked at, what are the barriers in care, especially in those centers where they, are taking care of those at-risk populations, to see what kind of things pop up and, to identify areas that we can potentially address when fixing systemic issues. But, some of the things they have found when looking at these different specialized clinics is there is limited knowledge among providers regarding the guidelines they should be following, like I previously mentioned. And then there's a lot of system level barriers. Okay, I've diagnosed this. How do I coordinate with providers among different specialties? How do I, we are quite familiar with this, but, different institutions use different medical records, and sometimes it can be hard to follow up on somebody's anal pap to know when their next exam should be, and then organization between multiple teams. So, the next thing we wanted to go over is what are the available resources and current infrastructure. So one of the awesome things about Dr. Ganz joining our department is we kind of were able to put together this missing link. We've provided in general most of these services, but one of the big deficits has been screening for anal dysplasia, and who should we be doing it for? How do we do it? And I think when you find somebody who's passionate about it and, it's a niche in their practice, they're excited to teach other providers. As a resident, I learned this one time in my 4 years of residency. And now it's so helpful because when I'm in clinic seeing somebody with VIN 2 or 3, I can hear Eric's voice in my head reminding me, don't forget to do an anal pap for them. And the first time I did it, I had already forgotten how to do it. I was able to run down the hall and ask Eric to review it with me again. What specimen cup do I use? And having a specialist within your center is really helpful. It makes you feel safe. You know who to specifically reach out to for help. And so the hope in building this dysplasia center is having somebody with a particular interest within each of these domains. So myself being the vulva and vaginal dysplasia person, that's my specific interest. Dr. Huma Farid being the cervical dysplasia go-to person, and Dr. Ganz being the anal dysplasia person. And the nice thing about not only having somebody who specializes and has a particular interest in that region, but when I have something come up, because as you'll see, having dysplasia in one area puts you at risk for dysplasia in another area. I know to automatically who I can send my patient to. They can go down the hall. They can have all their care under one roof. And Marty Florence, who is a nurse you are all very familiar with, helps go through, she will go through our lists, review who I've seen, make sure that an anal pap has been done among my patients, Huma's patients, follow up on the results, and then refer them to Dr. Ganz clinic. So it's nice that somebody is overseeing all of our patients and sending them where they need to go. And the other wonderful thing is having the support of the GYN oncology team for when we are making sure we're following the guidelines they're using, and having somebody for mentorship and guidance. And when we have complicated cases, it's really nice to, not only have their support, but their guidance as well. So, there are 2 other centers in the country who are doing this, U of Miami and UCSF. So as common as this is, it's substantially less common to have collaborative teams working to provide patients all of these services under one roof, one floor. And so we're hoping to, learn from this and be a template and a guideline for other centers for more cohesive care for patients. So it's easier for patients, but also for providers. So as I mentioned, it's the first in New England, which is really exciting. And it's a virtual center. The three of us are among different pods on Shapiro 8. We have an interest in each of the regions that I have previously mentioned. There's one telephone number, one order in OMR that has recently been revised so that it specifically now states lower genital tract disease center. And our goal is really to improve the experience for patients, so they're not jumping from multiple institutions, and for the providers as well, and to hopefully have improved communication among all the parties involved.
So I think the next part we really want to discuss is the anatomy. I think the anatomy of the anus is sort of very familiar and similar to the anatomy of the cervix. And so when we think of the anus is really only 4 to 5 centimeters in length. It starts at the anal verge and goes all the way to the dentate line. And so the question here is that the anal verge is the beginning of the perianus, and it goes from the anal verge out to 5 centimeters is the perianus. It is extremely morphologically similar to the cervix. It has a transformation zone, so clearly it acts the same way in HPV metaplasia, and it has all the similarities to the cervix. So let's talk about some of the risk factors. And I know we discussed this earlier in previous slides, but really there is limited data, and it really is there's limited data in healthy non-immunocompromised women, which is what we're sort of focusing on. But we do know that immunosuppression of any sort increases your risk. History of cervical and vulvar HPV-related diseases and lesions increases your risk, which I showed you previously. History of anal intercourse before the age of 30. Now, I know that people want to say that you have to have anal intercourse. At least a lot of the patients feel like they need to have anal intercourse or have had anal intercourse to have a risk factor, but that is absolutely not true. Anal intercourse is a risk factor, but it is not a necessary part of anal cancer. Older age, absolutely. As you get older, the increased risk for anal dysplasia and anal cancer, and the same thing with increase of sexual partners, just like for cervical dysplasia and cervical cancer. So here's some of the screening guidelines, and this is what Dr. McKinney was expressing before. There is a multitude of colleges and societies nationally and internationally that have given us various different guidelines throughout the past several years. The main society, the International Anal Neoplasia Society, is going to be the center and forefront of the guidelines of going forward. But that being said, until those guidelines come out from that society, we're still having a mixed match of guidelines. If you look here at the New York State Department of Health AIDS Institute, they just need anal cytology, visual inspection of the perianus, and a digital anal rectal exam. The Infectious Disease Society of America just says anal cytology for people who've had anal intercourse and abnormal cervical pap results or condyloma. You know, the American Society of Transplantation and Infectious Diseases Community of Practice only say anal cancer screening for patients with a history of cervical dysplasia. The European Society of Medical Oncology recommend against screening of patients with lower anal genital tract cancer. And finally, the American Society of Colon and Rectal Surgeons suggests just a shared decision-making with patients who are at high risk. So you see, there's just a a multitude of different recommendations. We have pulled together until the International Anal Neoplasia Society comes out with their recommendations and guidelines. We have pulled together these guidelines into sort of one set of guidelines, which I'll show you in a second. Anal cytology, let's just talk about anal cytology for a second, about for anal cancer screening. We know that it is the only way that we have right now for a screening test and a screening tool. It certainly underrepresents the grade of the disease. And what I mean by that, if you look at the anatomy of the anus, it has a lot of crypts and crevices. And so when you do an anal pap smear and you have a high-grade lesion, you probably have a high-grade pap. You probably have a high-grade lesion. That being said, when you have a low-grade pap or a NILM negative pap, you can't really necessarily say that you have a high-grade, that you have a negative lesion there. So you must actually look for a high-grade lesion. So the sensitivity, the specificity is pretty high, the sensitivity is pretty low. High resolution anoscopy like colposcopy is the gold standard. We normally don't use that as a screening tool, A, because of the expense, and more importantly, because of the it's severely uncomfortable. Lastly, if you look here, the detection rates, why do we screen? We want to screen early because we know it makes a difference. If you look here, that localized anal cancer, there's almost an 85% survival rate when it's at distant levels. Anal cancer represents only 35% 5-year survival rate. So you do want to screen and identify an early cancer before you want to identify an early cancer. So does treating this dysplasia actually work? We actually know that for cervical dysplasia, we know that if we do a LEEP or remove a cervical high-grade lesion, we could decrease the risk of developing cervical cancer. That being said, we had to have a double-blind randomized controlled study looking at that. And so the ANCHOR study, which is the Anal Cancer High-Grade Outcomes Research Study, was a large national multi-center phase 3 randomized trial with almost 4,500 participants, looking at HIV positive and 35-year and older. And they basically randomized them to treatment versus non-treatment. And they followed them every 6 months for 7 years. And it was actually concluded early because they found out that people who are, because they actually found out that treating patients with high-grade lesions of the anus reduced the chance of progression to anal cancer. So but that's a whole different lecture and study that we can talk about later. So how to screen and performing an anal pap. This is really crucial. This is where the average, the internist, the family physician, the gynecologist, anybody who's seeing the patient who is at risk should screen for an anal pap on those patients who are at risk. And you want to use a Dacron swab. A Dacron swab is just a trade name for a synthetic non-cotton swab. And you want to use a non-wood swab, although on this picture shows a wood swab there. You actually want a non-wood swab for obvious reasons. And you want to insert the swab. You just wet it with regular water. You wet it until it butts the flexure of the rectum. And you don't want to use a cider brush, even though that cider brushes sometimes are feel like it can get more of a adequate sample. There are studies to show that the cider brush versus using just a regular Dacron swab, there is no difference in unsatisfactory pap smear results. So once the swab is in, you rotate it in a circular fashion, pulling it out. You should be, I mean, I hate to say this, but kind of aggressive to get all the crevices and crypts of the anus. And then you bend it with slight pressure, count slowly to 10, and then immediately place it into the thin prep, shake it well. Personally, for me, I break off the tip of the swab and put it into the thin prep and shake it. The cells of the squamous cells of the anus dry much quicker than the cervical cells. So you really need to go from the anus into the thin prep pretty quickly. Do your digital anal rectal exam after. Do not do it before. The lubricated finger will upset getting the anal pap smear adequate results. So I do want to talk about the digital anal rectal exam. Everyone goes, well, I know how to do a rectal exam. It's pretty easy. You put just a finger in the rectum. That's actually not true. Well, that it is true, but the more important thing is how to identify areas of the anus and the perianus. The digital anal rectal exam is a screening tool to screen anal cancer, not necessarily to screen anal dysplasia. So I think that's a little bit of a difference. And it's really a very easy screening tool, right? I mean, it doesn't cost a lot at all. It's easy and it's fairly quick. So basically a digital anal rectal exam with the entire evaluation of the anal canal and the visualization of the anal margin, like I mentioned before, 5 centimeters to the anal verge. So like I said, evaluate the perianus, use a lubricant. I sometimes use a topical anesthetic. You want to use long circumferential sweeps in a 360-degree palpation. For me, and I'm sure for Dr. McKinney, we do our exams in dorsal lithotomy because we're also doing a GYN exam. That being said, for a lot of patients who are just coming in for a digital anal rectal exam and an anal pap smear, personally, it is, for me, patients prefer to be on their left lateral side to do it. It's just easier for the patient, more comfortable, and there's just, there's less, I guess I would say, less shame around the being placed in dorsal lithotomy. You would perform at least for a minute, and obviously note for any kind of blood or discharge on your finger. What about anal cytologic results? Because you will get these results back. What are you going to do with them? So in general, any abnormal result, you should perform a high-resolution anoscopy, which means sending them to the lower genital tract dysplasia center and having the lower genital tract dysplasia center, myself, doing the high-resolution anoscopy. During that exam, I would do the exam, I would do the biopsy, I would do the whole high-resolution anoscopy. If it comes back as low grade, I just follow up within 1 year. If it comes back as high grade, we talked about that. We treat that. We either treat that with 5-FU, or we treat that with, more importantly, with an anal ablation in the office. What about anal HPV testing? I think that's a big hot topic. I know that the International Neoplasia Society will probably use anal HPV testing in their guidelines. For now, it is not in their guidelines. There is no FDA-approved HPV test for the anus, because for the obvious reasons, it's a very high negative predictive value. There's a high prevalence of HPV in the anus. So for now, it is not in any guidelines per se. I can tell you in the near future, it probably will be. I'm going to leave this slide up for just a second. This is our recommendations that we pulled together, all those multitude of different societies and colleges guidelines, and we pulled them together to create guidelines that we thought at the lower genital tract dysplasia center that we thought were appropriate for screening and combined all of them into one document. So that's that. If you don't get that, you can certainly email us and we can send you those guidelines. This is actually, so I think this is, this here is when to refer to the lower genital tract dysplasia center. You know, I guess it's for any abnormal anal pap, and what about an unsatisfactory or inadequate anal pap? My suggestion is repeat it once. If it's still unsatisfactory, please refer. We can do it for you. The adequacy of the anal pap, unlike the cervix, does not necessarily include the presence of a transformation zone, unlike a cervical pap. So it should be easier to get more satisfactory pap smears. And any patients with lower genital tract condyloma, those are patients you can easily refer to us. I know that there are people on this webinar who are part of BIDMC. If you have access to OMR, this is what you should check. It's the lower genital tract dysplasia center right here. We apologize that there are a multitude of other referral sites here. Please don't use colposcopy anymore, but use this one right here. And I think the next several slides are for Dr. McKinney.
So essentially, like, who should you be referring specifically to the center that we've been referring to? Essentially, you know, many of us feel comfortable managing cervical dysplasia and vulvar, vaginal, and sometimes, you know, some of these other dysplasias. But if not, we're more than happy to take care of these patients and get them under one umbrella. We're happy to be points of contacts if you have questions. And like Dr. Ganz mentioned, to not use the colposcopy button anymore, but rather the button that now says LGTD, because then it goes to our team and can be resourced to the right provider. And one central person then can ask the questions between the three of us. Who should this patient go to? And, you know, and essentially, is it for patients with pre-cancers, not cancers? Those will still go to the GYN-oncs. Again, that includes cervix, vagina, vulva, and anus. Just a few references regarding the other specialty clinics, because it can be confusing. In terms of the vulvar clinic, right now patients call or they will email me directly and I'll message my provider that helps with admin. Patients are still technically coming to the vulvar clinic, but if they're coming for dysplasia, I'd prefer if you just use this one central order button that we just mentioned. One, it helps them get in much quicker. It makes them a more urgent patient. I think the vulvar clinic is booked out, you know, over a year, unfortunately. But if they have dysplasia, we get these patients in substantially quicker, usually within 2 to 6 weeks. And then, you know, the same is true for these other order buttons. Your gynecology, they have their own specific button. A complex family planning issue, separate button. Gyn-onc for actual cancer or for patients with known genetic mutations who put them at risk for cancer, those still go to GYN-onc. And then for any other GYN conditions that's not a pre-cancer, or something that I've mentioned before, the same GYN consult button. And somebody is triaging those, you know, emails. And I do get emails sometimes asking, are you the right person for this? You know, and so that it's going to the right person.
So I think this is it for our slides. There was a lot of information. I appreciate everybody sort of listening, and so I'm going to stop the slide show now and see if we can, if there's any questions in the chat, we can go from there.
I did want to mention one other person on our team, Mary Beth Maservi, who's the nurse practitioner who many of you are familiar with. She will also be a part of our center and assisting us with screening and making sure that patients are getting the right treatment. And so it's nice because we have the three of us, the MDs, we have Mary Beth, who will be incredibly helpful, and then having Marty Florence as our nurse and, you know, helping coordinate care. So I just wanted to give a shout out to her as well.
So there is, thank you, Dr. McKinney. There's a question here from an anonymous attendee. It says, a minute is a long time to have one's finger in one's rectum. Your point is extremely well taken. You know, I think, you know, doing a good digital anal rectal exam is important. Obviously, it's important, you know, you also have to understand if the patient is uncomfortable, you know, obviously do it much, much less. That's all I have to say about that. I think the next question, it should be for Dr. McKinney. Do you see that? Lichen
sclerosis should go to vulvar clinic or lower genital tract disease center. That should go to the vulvar clinic. Unless your patient now has lichen sclerosis that is resulted in differentiated VIN and has resulted in a precancer, then that would be a reason to come to the dysplasia center, and we would get that patient in much quicker.
I don't think we have any other questions on here. I hope we answered everybody's questions.
And I hope people feel comfortable emailing us. I love it when people email and ask questions. I frequently email Huma and Eric, and we're often running cases by one another. You know, my hope is that with this dysplasia center, people feel safe and comfortable approaching a generalist with questions. We're all colleagues and work with one another in other settings. And I hope this can be one more setting that we can work together and, you know, learn from one another. I've learned so much from Huma and Eric. And so we hope to be, you know, guides to you guys as well. And I'm never bothered by these kinds of emails. I love teaching people so that, you know, sometimes people want to be able to do this for themselves. And I love precepting vulvectomies. I love helping people and guiding them regarding these things. So please don't ever hesitate to reach out to us regarding these conditions. The more people who know, the better.
Right. I totally agree with what Dr. McKinney is saying, and I really, really appreciate that. And thank you, Diane, for your comment. Thank you. Do we have any more comments or questions? I think hopefully you will see, just sort of as a plug, please do anal PAPs on those patients who need it. And that's about it.